In April's Tynwald sitting, the Health Minister moved a general debate on the mandate to Manx Care and Manx Care operating plan. With the recently announced resignation of Manx Care's Chief Executive Teresa, I thought it was timely to listen to highlights from that debate. First, the Minister introduces the debate.
This mandate and operating plan set a clear direction for 2026-27 to improve access and outcomes for patients and service users and strengthen community-based care and embed the governance and financial discipline that the public rightly expects. They also make the basis for accountability explicit. Members will be able to see what has been promised, how it will be delivered, and how performance and spend will be monitored throughout the year. Where delivery is not on track, there is now clear routes for escalation and recovery. I do not underestimate the scale of the challenge ahead. Demand is rising and the workforce remains under pressure, and decisions we take must always balance ambition with what can be delivered safely and sustainably. And that is precisely why these documents matter. They bring focus, prioritisation, and a disciplined approach to delivery. I welcome members' contribution in this debate today, and I ask for support for the direction of travel set out in the mandate and operating plan. Where members raise concerns or constructive challenge, I give my assurance that the Department will engage openly, and we will work with Manx Care and partners across the system to respond. Finally, I again place on record my thanks to our staff and to everyone who supports health and care services on our island. Their commitment is the foundation on which every improvement depends. Therefore, Mr. President, I recommend the mandate to Manx Care and Manx Care Operating Plan 2026-27 to Tynwald.
That was Health Minister Claire Christian. Joni Farragher's next.
I do have a brief contribution to make. Just because when you read through the mandate, there's a pattern that keeps coming up. The language is quite cautious, where funding permits, explore, contribute, submit a plan. And the difficulty with that is that it describes activity, but it doesn't always tell us what will actually change and how patient outcomes or service user outcomes will be improved. You can see that quite clearly in the section on NICE technology appraisals. In the UK, NICE technology appraisals, or NICE TAs, are national decisions on which treatments work and are worth funding. And they are effectively mandatory, but here they're treated as optional rather than expected. We're told these will be implemented where they're cost neutral, and further adoption will happen only where funding permits. And that phrase, cost neutral, is doing some really heavy lifting here. Most NICE appraisals aren't cost neutral in the short term, so implementation is being quietly limited here. It creates the appearance of compliance with NICE standards while allowing non-implementation on financial grounds, but without requiring transparency on what's being rejected and why. When we talk about NICE TAs, it's not abstract. These include treatments people will recognise, such as the weight loss medications like Wegovy and Manjaro, now introduced in the UK NHS following NICE approval. These aren't cost-neutral interventions in the short term. They require upfront investment and system capacity to deliver. But the important point is this: NICE doesn't assess cost neutrality, it assesses cost effectiveness over time, in the long term. So many of these treatments are approved precisely because they're expected to reduce future demand on the health service, preventing more serious illness and improving long-term outcomes. So, for example, with the drugs like Wegovy and Manjaro, they reduce type 2 diabetes, cardiovascular disease and hospital admissions. But we have no plans to introduce these here because they don't meet the short-term cost-neutral test. So we're ruling out the very interventions that could deliver the greatest long-term benefits, both for patients and for the sustainability of the system. This cost-neutral test focuses on today's budget, but NICE is designed to look at tomorrow's savings. And I think this is a clear case where we're becoming more and more behind. Each year we allow this to continue, and the harder it will be for us to catch up. And moving on to the stated ambition around early intervention, prevention and childhood experience, and that is undoubtedly the right direction of travel. But when we look at the section on children's services, we can see similar language patterns appearing. We're asked to produce plans to explore issues such as re-referrals and to maintain safeguarding arrangements. All of these are important, but they're largely descriptions of process. They're not commitments to measurable improvements in outcomes for children. And I want to reiterate a point that I've made previously, and I'm sure that a lot of people will think this sounds very familiar to them. Performance management in children's services, well, in all areas of social care, should be just as clearly defined and outcome focused as it is in health interventions. If we can set targets for waiting times and clinical outcomes, we should be able to define what success looks like for children and families. We need to link intervention with outcomes, not measure administrative functions such as the amount of meetings held. That's not meaningful. It doesn't tell us how effective services are in genuinely helping a family in need. And that's what children's services are for. And it really does feel like sometimes that's been forgotten. Moving on to prevention initiatives. Again, the emphasis is on contributing, collaborating, submitting plans, often with delivery pushed into future years and evaluation not expected until 2027. Responsibility is shared, timelines are extended, and success isn't clearly defined. Now, I do fully accept this is a high-level mandate, and it's not meant to contain operational detail. But even at a strategic level, we should expect clarity on three things: what's being prioritised, what will change, and importantly, Ectaren, how success will be measured. And when we turn to the operating plan, which is meant to translate this mandate into delivery, those same limitations remain. Prevention and childhood experience are named as priorities, but without clear, specific or measurable commitments attached to them. And within all of this, Ectaren, there is a notable absence, which was pointed out yesterday and which I will stress again today because it's important. We have this month approved a plan for neurodivergent pathways, an area that sits directly within early intervention, childhood development and long-term prevention, but it's not referenced in the mandate or the operating plan. So the concern is this: if something's not clearly prioritised in the mandate and it's not clearly defined in the operating plan, and it's also subject to funding constraints, how can we be confident that it will be delivered? Maybe the Minister can confirm today that it will be added to the mandate if it's given funding approval in future. In summary, Ectaren, what's described here is often too activity-focused: plans, reviews, collaboration, but what we actually need is impact. How will things actually change for a child? How will patient outcomes be improved? What will actually improve in prevention? And how will we know? At present, I'm just not sure this document answers those questions clearly enough.
That was Douglas East MHK Joni Farragher. Alex Allinson also spoke in the debate.
In terms of the mandate to Manx Care produced by the Department for Health and Social Care, I have no issues with this. It talks of all the right things. But I would think that the actual operating plan is often devoid of detail. I think when you read through it, often there are excuses laid down in terms of lack of resources, lack of digital infrastructure, and also lack of money that might stop them delivering the mandate. And I think that comes down to one of the key principles that the Minister's been trying to pursue, which is the governance issues. That we have a mandate here which states what we want. We have a budget which has been stated is enough. But as the Honourable Member for Douglas East has pointed out, what is more important to the people of our island is the outcomes that they feel, the experiences they have of the healthcare they fund. And so I think linking these together is very important, but the operating plan needs continual review. And that's where we come into the role of the Manx Care Board itself in terms of making sure that if there are issues that inhibit Manx Care providing the mandate outcomes, that those are flagged up to the department very quickly, and those are then solved, or at least resolved in a way that allows those outcomes to be delivered. Because only yesterday we heard that the people on an urgent waiting list for ENT services could be waiting for up to a year. There are some really good issues in terms of the getting it right first time, in terms of patient-initiated follow-ups, which will help with some of those waiting lists. But again, it's putting the patient first in the whole system and making sure that we try to retract from what has become over decades very much a noble-centric system of healthcare. Some of the initiatives in terms of the wellbeing partnerships in all four corners of our island show real potential for bringing localised care and anticipatory and primary care to the forefront. But unless these have the right resources, which will entail some transfer from secondary care, they will not succeed and they will not be resilient enough to continue to develop. I also think it is absolutely imperative, as we have said around about every 5 years, that some of the work on the single integrated digital healthcare record is achieved. When Sir Jonathan Michaels did his original report, he saw that as the key driver for efficiency in the healthcare service, but also the key driver to put, the patient first, so that they would have access to the records, that the individual consultants and teams who may be looking after them were allowed to overcome what has become a very much fragmented system where we have over 100 different IT services being used. And whilst a lot of work has been done on this through the transformation team, I've yet to see any outcomes in terms of when and how we will achieve what is essential for a healthcare system, particularly with the complexity it now has. I also would like to suggest that we stop referencing Sir Jonathan Michaels' report. It was a very good report, but it was in a very different time. The funding model it proposed, based on inflation and cost savings, was a good idea. But has it worked? And the answer, on the facts that we have before us, and the Honourable Member for Council, Mr. Cluder, said, is it hasn't. They've got what was written by Sir Jonathan Michaels, and they say that's enough. But will it be enough for next year or the year after, based on inflation, based on increased complexity of costs? And the Chief Minister has been giving updates in terms of the recent conflict in the Middle East. We have yet to learn what knock-on effects that may have for things like pharmaceuticals and other inputs to healthcare. So I think we need to get away from the original report of St Jonathan Michaels. We need to look at what is needed to provide for the outcomes in the Manx Care mandate. But I would like to wish the Minister all the best luck for working with the Manx Care Board on a regular basis, get the governance right, so that we have regular checks and balances to make sure the mandate that I think we can all sign up to is actually delivered with the right outcomes for our people.
Ramsey MHK Alex Allinson. Next, Gary Clewett, who began by praising the Manx Care staff.
My gratitude to the staff does not extend to the blind endorsement of the financial arithmetic placed before us today. We are presented with a mandate and operating plan that talks a very good game about home first, early intervention and integrated care. But when we scratch beneath the surface of the glossy corporate language and scrutinise the numbers, we find a budget built on optimistic assumptions, unresolved systemic flaws, and what I can only describe as fiscal magical thinking. Manx Care has a well-documented history of overspending its budget. For 26-27, we are asked to approve a significant budget uplift to £404 million. This is an increase of £42 million, or 12%, from the 2025-26 starting allocation. We're told that for the first time, the funding formula recommended by Sir Jonathan Michaels' independent healthcare review has been applied. On paper, the uplift of £42 million should inspire confidence. Yet, having critically analysed both the mandate and the operating plan, I have very little confidence that Manx Care will live within this envelope. Let me outline exactly why. I'll now address the inconsistencies in the illusion of a balanced budget. When we look at the financial planning assumptions in the operating plan, the inconsistencies between the mandate's strategic demands and the budget's fiscal reality become glaringly apparent. The funding formula applied is 3.03% growth plus 2.9% for the Isle of Man Consumer Price Index minus a 1% cost improvement program constraint. But Ector applying a general local CPI of 2.9% to a healthcare organisation is a fundamental mismatch of reality. The operating plan itself admits that UK CPI is running at 3.8%, and more terrifyingly, that health inflation is running at over 17% during 25-26. The cost of clinical consumables, specialised tertiary care, and pharmaceuticals procured via NHS supply chain is rocketing far beyond local baseline inflation. A mandate that expects Manx Care to absorb 17% medical inflation with a 2.9% inflationary uplift guarantees an overspend before the ink is even dry. Furthermore, Ector, let us look at the so-called cost Improvement Programme, or SIP. To balance the £404 million budget, Manx Care must deliver a 2.5 to 3% improvement in recurring cash out. That equates to £9.7 million in recurring savings. Now let us look at the history. In the current year, Manx Care forecasts a £10.8 million SIP achievement, but a staggering £6.1 million of that was non-recurring. It was effectively a one-off savings. To pivot from a position where the majority of savings are non-recurring to a year when we suddenly expect nearly £10 million of permanent cash-out recurring savings is a monumental operational risk. I would go so far as to say it is highly unlikely to be achieved. If this SIP fails to materialise in cash terms, the £404 million budget will be blown out of the water by the second quarter. So what are the areas of concern? Beyond the headline number, the operating plan exposes severe vulnerabilities across the system, what the document refers to as key enablers, but in reality are key structural failures. First, there is an alarming misuse of the non-recurring healthcare transformation fund. The department has sought 5.4 million for this fund for 26 to 27, but what is it paying for? It is paying for the rollout of health in the care communities, for the ambulatory assessment and treatment unit, and for the very financial recovery program tasked with saving money. The misuse is not even hidden. Page 29 of the operating plan explicitly states this funding is non-recurring in nature and therefore should not be used for recurring investment. Using non-recurring transformation funds to prop up core recurring operational expenses is a dangerous game. When the £5.4 million transformation fund pool runs out, those services will still require funding, creating a multi-million pound cliff edge for 27-28. This is an area of acute concern. We are masking our base revenue deficit with temporary transformation cash. Second, there is the broken shared service model. The MIA governance review has already highlighted this, but the operating plan lays it bare. Manx Care is an arm's length body, yet one arm is timed firmly behind its back. They do not control their own IT, HR, or estates, although I must say that including the cost of these would increase the £404 million headline number. The operating plan notes that they are trying to deliver 21st century healthcare out of decaying buildings, specifically citing the emergency department, the level 3 containment lab, and Cummill Moor. They are reliant on government technology services for failing fragile digital infrastructure. It is entirely inconsistent to mandate strict performance and efficiency targets for an organisation while withholding its control over the very levers required to achieve them. We see this dysfunction most clearly in patient logistics. Third, we must address the glaring dysfunctions surrounding the patient logistics and off-island care. As an island, we are heavily reliant on the northwest of England for complex care pathways. Yet according to page 48 of the operating plan, air traffic control challenges have forced us to rely on His Majesty's Coast Guard for emergency transfers when our fixed-wing air ambulance cannot operate. These Coast Guard transfers are roughly 3 times more expensive. This is a staggering premium to pay for infrastructure failures outside of Manx Care's direct control. Furthermore, we see the transfer of the non-emergency patient transfer service, the NEPTS, from the Department of Infrastructure to Manx Care seems entirely stalled. Why? Because of funding disputes. The service is not CQC compliant. Of course, the question arises as whether NEPTS needs CQC compliance for mobile patients who could ordinarily simply take a taxi. This is yet another example of government departments arguing over the checkbook while the continuity of patient care hangs in the balance. Fourth, and perhaps most frustratingly, we are erecting our own barriers to the much-lauded Home First strategy. The mandate heavily prioritises moving care out of the hospital and into the community. It is the right philosophy. But the operating plan honestly admits that a major barrier to this is our own statute book. When we aggregate these factors, the trajectory is undeniable. We have a £404 million settlement, but we have £9.7 million in highly speculative recurring savings targets, a 14% gap between the funded CPI uplift and the actual health inflation, unresolved high-cost off-island patient packages, which account for £9.6 million pressure at the end of last year, extortionate premium costs for off-island emergency transport due to infrastructure unreliability. Unless a miracle occurs, Manx Care will plunge into a deficit. The structural deficit has not been cured. It has merely been rolled over, wrapped in a higher baseline, and offset by phantom efficiency targets. If we are to stop this endless cycle of supplementary votes and budget blowouts, we must reinforce immediate and robust controls. We can no longer afford the illusion that we can efficiency save our way out of this crisis. The time for kicking the can down the road has passed. Hard decisions must be made, and they must be made sooner rather than later. We are facing a fundamental democratic and economic dilemma, and we owe it to the Manx public to be entirely honest about it. We cannot demand a limitless, world-class health service while turning a blind eye to the skyrocketing real-world costs of medical care. Ultimately, we are hurtling towards a cliff edge where the only two realistic options remain. Either we must seriously look at rationalising services, having a mature, inevitably painful conversation about what the state can realistically continue to provide free at the point of delivery, and what may require alternate funding models, co-payments, or reduced scope. Or, if we're absolutely committed as a Parliament to maintaining the current breadth and depth of universal provision, we must be honest with the taxpayers of the Isle of Man that it will be requiring raising taxes to pay for it. There is no magical third option, and hoping for a £9.7 million in recurring efficiency savings is not a strategy, it's a prayer. Until we are collectively willing to confront this binary choice, to rationalise services or raise taxes, we will be back in this chamber year after year debating yet another multi-million pound overspend, while our reserves evaporate. Gurmayo.
MLC Gary Clewett there. Health Department member Peter Reid offered some gentle rebuke to his Legco colleague.
I'd just like to respond to some of the comments from Honourable Member of Council, just in terms of the finances, and I think he did an excellent job of summarising again a lot of the risks that we face within our care service for the island. And, we also talked a little bit about that in terms of the international supply chain. I was a little confused there. I wasn't sure whether you were arguing that we should have had more budget in the first place from Treasury, or whether you were actually arguing that we should raise taxes for our healthcare, or whether we should actually cut services from the healthcare. So maybe that's something we could talk about offline. But I do think that when we read the mandate this year, it's quite a different mandate to what we've had in the past, particularly in that we seem to have in the past looked at what we said we'd achieve and then give excuses as to maybe why we hadn't got to some of those goals that we had within our mandate. This mandate is a mandate of matching the money that we actually have to the service that we need to give to the island. And I think that's a very important point. And, going back to some of the comments also around the fact that certain things aren't in the mandate, that's because they're not costed. And because they're not costed, they won't be delivered in that mandate. I also think that there's a number of firsts with this mandate. The fact we're talking about activity-based costings, and also talking about demand, which is the need that we have, and seriously trying to quantify that and what that value is, not just in terms of monetary, but also in terms of the value that we have to deliver to patients, in terms of reducing waiting times, in terms of the care. That's seriously considered within this mandate and then matched within the operating plan. So, although, I probably would agree with some of the comments that we're not there yet in terms of itemising that, we're a long way forward than we were before. And I would suggest to you that that's something that as we go through this year and we look at this operating plan and this mandate, we have got structures in place now to actually review that properly and start to measure properly the demand, the need that we have against the money that we actually have there. I would also argue that what you were talking about in terms of the way that we're going forward and that, we've been forever asking for money, this could be a different year. This could be a first year and time will tell. However, I will certainly be doing everything I can to make sure that as we look at the finances month on month, that we are looking at that need and matching up that budget that we have. So, I'd welcome if you'd like to give us more money from Treasury. Always that would be very welcome. But I do thank you for your comments, sir.
MLC Peter Reid there. So what do you think? Will we ever be able to afford the best and most up-to-date health services? If so, how will we raise the funds to pay for them? Do we need to be more realistic in our expectations? I'm Phil Gorn. Go to Myers and Geisach from. Thanks for listening.